So we start with arthroplasty session, and Brigadier SOOD here will speak about complex reverse arthroplasty.
Case, it's an ordinary case, but just that how we do it. And I'm just primarily not a primary shoulder surgeon, but just want to bring out a point about how we went about planning and doing a case in our institute. It's not about surgical prowess, which I've seen in yesterday and today itself. It's about just going about it in a different way. So that's my credentials and no disclosures. Lady, she was actually sent to us from another center, since we have a referral system, which is actually Secunderabad. She came from. History of trauma 11 months back. In a private hospital, she underwent a close reduction twice, which failed, went home, put a Velpu dressing. Twice it had happened over a period of 3 weeks, but somehow she always kept coming back, and even the radiological workup was not done for her too much. She didn't have much X-rays. So eventually she was given a shoulder immobilizer, and then finally when her son came back from leave, she brought her to the military hospital. So she had this right shoulder pain, restriction of movement, 77-year-old, but still had a problem. So there was instability. Whenever she finally presented to the military hospital, she had inability for internal rotation and a weak deltoid contractions, and probably a neglected fracture dislocation of suspected. Because the internal rotation was restricted, they suspected much more than a simple neglected dislocation and sent to us. This is the radiograph it looked like. Please do remember it's about 11 months old. She's 77 and osteoporotic, and a little bit of glenohumeral arthritis are already started setting in. Of course, the first thing is just to take a CT scan. This was also done there itself. Anyway, we processed it in our 3D printing software, which gives us a little better imaging. As you can see, these images are from the segmenter software that you get, and you get far better images than you can get from a regular CT scan, because it was just 2 mm or 3 mm sections which are there. But you can process the images a little better. You can do a little better planning. So this was the image which we from the old CT scan which we had with us. And as you can see, there is a gross, if you see the axial view, there is a gross anteversion of the whole glenoid. A large part of the glenoid is actually missing, which I'll show in the subsequent slides, and malunited or resorbed, and so that was the situation. As I said, I'm not a very confident shoulder surgeon, but still we had to do this case. So I did opt for trying it out and doing it some other way. She had an MRI already with her. So MRI showed a rotator cuff tear. So with this radiological picture, a rotator cuff tear, the management option is very clear, and that's why I put the ARS at the end of this presentation instead of putting as an option. One of the things that was there is she hadn't moved the arm too much. She had a lot of deltoid wasting, so we were a little apprehensive about the deltoid. Though the regimental badge sign was normal, still she underwent a EMG where it came out to be normal. So we put her onto a prehab program, gave her some NMS, sent her back to Secunderabad, and called her back about 3 weeks later, but she came a little later. Anyway, so that's the time we did do some prehab, which is basically neuromuscular stimulation. So that was the problem that we had, and in the meanwhile, we started thinking of the other options. So problem was this, that was, of course, she had to undergo an intervention, but this was the problem. She had almost, if you calculate, more than 50% of the bone loss was there, a little bit more probably. Rotator cuff was gone. She's 77 years old, painful, restricted mobility, wanted a solution. So this time when she came back, we did the other side glenoid. Though we know that the glenoid width are not too much, especially in Indian females, would be around something like a 24, 25 mm. But still we went did a contralateral glenoid and tried to match it at how much to quantify the bone loss and see if it could do something about it, or can we do it in 1 stage, 2 stage, or what to do also. Can we, what is the, so what was the management plan is that should we do obviously the management plan was a reverse shoulder and a bone grafting procedure. How to do it was the question. Should we do it in 1 stage? I had initially seen where in my fellowship days as a 2-stage procedure, where they were doing a 7-shape graft, something like the one we saw some time back, and used to dovetail it on there and leave it like that and call the patient back. put a very large graft, and it used to take all the resorption back, call them back in about 8 to 9 months, and then do the reverse shoulder. But this is something that that was initially the plan. But after the 3D planning, as I'll show you, we actually became brave enough to go for a single stage. Okay. Also, in the meanwhile, we wanted to know which implant we should use. There we selected the Zimmer one, which has a small mini plate, which is 25 mm, and it has got a porous on porous coating. So these things were sorted out in the time that we got. Okay. So ARS questions I put in the end, that's fine. ARS question I put in the fine end. So how we went about going on to a 3D thing is, but last mein kar lunga. Okay. So how I said is that we were already having a DRDO funded project where we have this small desktop 3D printer, where we had started doing work on this, where this is right now in Army Hospital, and these small little jigs we were making there with the help of course, the 3D planner. These are already existing, nothing new in this, and I'm sure many of you would have used it also. So this was in the development stage. The only thing is we were printing it ourselves instead of them doing it for us. And as such, the printing cost is not much. It's the planning, which is the main thing. And we were using it for similar cases which are a little complex. They are okay, but if you can use it, it gives a little better insight into what you are heading for. Let's say in a shoulder like that, which is on top, and you can get a little better view of that. And various designs are there. So 3D. Another point I would like to highlight here is that if you're using these softwares, you get a better insight in entire all around the view. You can toggle the views around very well, like you can do in a 3D in a 3D view of a CT scan. But the quality can be improved, and you can kind of draw things and even take sections. So that gives you a better insight than a regular CT scan 3D model that you see on your screen. Okay. So as you see this, after this, once we saw this, we could make out that the antivergent angle was something like 76 degrees, which was really large. It's marked out there. And the inclination angle was still manageable. But this red line that I show in the middle finger is the one which actually gave us the hope that there was something possible, because there was bone here. There was bone possible here. I'll show it in the subsequent sections. And this is how you can segment it and see. So, this is the bone when you segmented it. Okay, so that's what gave us hope. This is 27 mm, and if you can put a 25 mm screw here, that could hold. And similarly, there was possibility of putting two on top. There was the problem that we had to this from the top actually, and you have to kind of give it a little bit more of antivergent. The glenosphere had to be given antivergent to engage. Otherwise, it was not possible to do this case. So I just want to bring out that how you can plan. The other thing is that, as I said, it's nothing about surgery. It's about planning and about having no dark corners when you are going for a surgery of this sort. I'm sure a lot of experienced surgeons are there. They must have done a lot of cases like that. But if you have the plan and it's clear to your assistants, you can really go with it really quick and actually execute what you plan on the images. So this was it. This is about 13 mm of it left. And as far as we saw the contralateral side, it was about 28 mm. She had the whole glenoid. She had 13 mm left, and rest of it was all slopey. But the good thing was it had good quality of bone. It was really hard corticalized bone because of the constant pressure because of the dislocated head. So as you see, this was the planning. We superimposed that glenosphere that we want to do, that's 25 mm. Put a graft. This is also pre-decided that this graft would be this size. That takes a lot of time out of the surgery because you don't have to measure it, have any ambiguity. You can just give it to the assistant. That is the humeral head, and he knows exactly how much to cut and do it for you. And the cancellous screws, everything can be planned in advance. And really, you don't have to. You can simply drill and go ahead, and not to bother too much if you have an image like that. The important thing is making the guide, and this is the advantage of 3D printed guides, that you can verify the guide at all three axes. This is a guide verification, and I'll show it in a video there. And that's the final guide we made. If you can sit, I'm sure this 3D, if you see the 3D printed guide, which is actually based on the coracoid undersurface, is the only way they could do it. It could not be sitting on the glenoid. But this is the one which can kind of give you the confidence to do this case. Most of the times you may have to play around during the theater time. So a small video about how to go about it and how it can help you planning things. There's the final guide which was made. So this is the off-take about patient-specific instrumentation. And I said that we already have a running project about knees, and we could use the same resources that we had, the software as well as the know-how to kind of think it. That's how you can plan things so well here. It's much easier, and most of it you can do almost like a virtual surgery here. And I think in this case, the only thing which is really important is to putting a peg into the bone. And if that is not good, the surgery may not work out. And that's exactly what we are looking at, putting the central peg right and having a good coverage, avoiding notching. So that's the virtual surgery you can do for you. That's something which the software engineers did for us. This is the final guide that you can make. You can practice it, that's the shoulder. You can practice it once on table, okay? And use that, and you have not much of ambiguity when you go in for the next soldier. So that's how, there's a paraprison that a head is split. There were little gaps inside that. You can exactly measure it. That's the guide outside there. It fits very well, though it looks it may not, and but somehow it really fits very well. And it's taking the footprint is on the undersurface of the coracoid, which you may have to clear out with soft tissue. We went for this Zimmer implant because of the small size, the mini plate is available, and it has a screw length which right up to 40, but what we needed was about 25. And these are the few images. I can bring out these. इसको click करना पड़ेगा. इन सबको click करना पड़ेगा. So I did this. You must do this on table because sometimes this is 2.7 mm and it really doesn't go. The 3D printing is not that exact. So you may probably have to drill it through once and make that hole right. In बाकी को भी click करें. Okay. All right. So anyway, that was the final result of it. And I just wanted to bring out this, that if it was not, had I not known it, that it will, the center screw will fix very well and the two supporting screws will fit very well, I wouldn't have been so confident about going about this surgery and doing this thing at the end of it, and reaming and the plate preparation that we didn't work. That was the final result. And unfortunately, she's gone back to Secunderabad, and this is the 3 months thing which was there. And now there is no other X-ray or a video I have. We talked to her about a week back, and she says she's all right, but she's likely to come in January when her son comes back from leave. So this is the post-op X-ray. I'd just like to summarize a few things about it. That I personally feel that though I do a lot of work in this stuff, that there is a role for something like this in the shoulder too. Knees definitely is very well accepted, and hips also it is coming in a big way. As an intermediary between tech, which is bigger tech and costlier tech like robotics and navigation, which we don't have in shoulder right now. So intermediary, it's a low cost tech you can use for certain aspects of the surgery, not the complete aspect, till we get a higher tech which is more viable. I think CT-based planning should come in such cases, and maybe even ordinary cases. Most of the revision cases may not always be simple rotator cuff tears or 4-part fractures in old elderly. There may be some kind of revisions that we are doing, and some anywhere where you think that there is a glenoid abrasion or glenoid bone loss is there, you may use this to be extremely sure about where you're going to put that screw.